I'll introduce you. Good afternoon, everyone. Welcome to Global Health Week, second day. Thank you for attending. And as you know, this is in collaboration with Diversity Week here at the University and the Health Sciences Center. So we appreciate your coming and your support of diversity, equity, and inclusion. There'll be a talk every day the rest of this week as well in here. So I hope you can attend. So thank you again for your support. I'm Melanie Fisher from the Global Health Program Director, and I have the privilege of introducing today's speaker who's with us. This is Dr. Vinay Badhwar. And Dr. Badhwar is Executive Chair of the WVU Heart and Vascular Institute. He's also the Gordon F. Murray Professor and Chair, the Department of Cardiovascular and Thoracic Surgery. And he's here to share with us his experience and with colleagues, some work that demonstrates, I think, equity or a desire to have equity in healthcare globally. So Dr. Badhwar.
Well, thank you so much. Can you hear me okay, folks? So it's an intimate crowd. Sorry to interrupt your lunch here. I'm glad you're eating, though. That's good. First of all, thank you to Dr. Fisher for the kind invitation. As she outlined, I work over at the Heart and Vascular Institute. You probably know of its existence, and it's a multidisciplinary effort through WVU, and I serve as its chair. But also, my daytime job is I'm a heart surgeon, and so this little story I'm going to tell you is about some efforts along these lines of dedicating ourselves to more than just clinical care or scientific care, but dedicating ourselves to the same mission that we have here at WVU, but taking it globally. Of course, I have no financial disclosures. I would posit that global health, I'm not sure how you get rid of this. There we go. I'll put it down there. How's that? That global health and all of the efforts of global health, doesn't matter what country you're in or what organization you're with, is really in the business of need, and that's including identification, operationalization of the problem, and organization of the problem, and then finally making it reproducible, expandable, and sustainable. Currently, worldwide, there's over 4.5 billion people that are currently living without access to life-saving heart surgery. This picture outlines, in the darker tones, are areas that actually have access to life-saving heart surgery in any of its forms. And you can imagine the rest of the globe that has an extreme paucity of access. Why is that important? Well, you might think heart surgery is this sort of thing in the background that only older people get, but that's not the case. Heart surgery's existence is to fix structural problems of the heart. Those structural problems, yes, they can exist in older people when their valves go bad or their arteries aren't so healthy. That's probably what you have heard of heart surgery. But across the globe, the most common reason for heart surgery is in younger people that have valve or congenital problems. I'm going to talk about my experience and our team's experience in one area as an example of how this is applicable across the globe, and that's in the country of Jamaica. Many of you know where Jamaica is. It's in the Caribbean, and Jamaica sits in the global stage with a gross national income that I would be considered low to moderate, yet its healthcare expenditures are about half of most developing nations. The 5 most populated Caribbean island countries are listed here, and all of these sites, when we started this effort, referred patients to Jamaica for heart surgery because we were there, including Barbados, Bermuda, Bahamas, and even Venezuela. Now, in recent years, a few of those countries have started their own fledgling programs, but still, there's still an incredible lack of access to care. So if we were to look at the management of need now in these two broad categories, let's work at our first area of identification, authorization, and organization. In the many years we've been going to Jamaica, in 2006, we've started significant development and planning. So we had a team go down, did some surveying of what the need assessment was, what the actual capabilities were. In 2007, and I'm fast forwarding a decade of experience, there was a lot of organization and planning and sending supplies, and I'm sure you've heard this through Dr. Fisher's experience and many others. It's a huge, not just a team, it's a village that it takes to create this, and oftentimes quite a substantial cost to get things started. So I'll spare you with those great details, happy to discuss them in the discussion phase if you'd like. But importantly, in this process, we actually trained surgeons in Jamaica. And so in 2009, the very first surgeon we helped train became an attending surgeon. And since that time, we can look at these big milestones. In the very first year, the cases we were doing, all by the visiting surgeons, and only, this is called atrial septal defect or ventricular septal defect, very basic. Before I continue, how many of you are medical? Oh, all of you guys. Perfect. Good. So forgive if there's anything you don't understand. I'm going to just flip to the little bit more medical side. So and if you have a question midway, feel free to interrupt. So by the 8th year, 80% of those cases were done by the local surgeon and a local team that you have listed here. And the team started doing at least 2 cases per week in that environment. And when I show you what the resources are, you'll find that that's actually doesn't sound like much, but there it is. And then at the end of the 8th year only, all of the relative quote unquote simple cases weren't available because all the surgeons, the local team did them all. So that's the point of impact. And we started doing a lot more complicated cases, and then also working on infrastructure and financial support and even building. This is the volumes. The volume started back, when this whole thing started in 2000, nearly 20 plus years ago, where they just was very fledgling basic care, and some of them not even with the heart-lung machine. Now, when you add that and you start to expand, in the last decade or so, they've been doing quite a substantial amount, and you can see the trend increasing. But it started from humble beginnings. The hospital that we have been working with and partnering with is called the Bustamante Hospital for Children. It is an old colonial British Army's barracks. So the British Army, as you know, populated much of the area, and this was literally their barracks. Now, when they vacated, the Jamaican government started to refurbish it and turn it into a children's hospital, an open air hospital. And so the physical plant remains the same, but for example, many of you go to outpatient clinic. This is the outpatient clinic. So this is where people come right off the parking lot. And, one of the entry signs is this. So you can say, it says, it's basically a broad clinic of everything. Doesn't matter what you have, whether it's surgery, prevention, and they have some dress code issues for some of the parents. Now, this is the picture of some of the open air wards that are previous Army barracks. And this is actually the view from the OR. A much nicer view, if you ask my opinion, than we have from our ORs. This is the view. This is the lawn keeping technique using a machete right outside of our OR. So it's a pretty basic situation. Now, in this process, they were very good about educating on rheumatic heart disease. So as you know, untreated streptococcal infections, usually oropharyngeal, can lead to bacteremia, and in the juvenile state can lead to inflammatory responses of the mitral valve and rheumatic fever. Now, we were dealing with that entity, which is where I come in, and we're also dealing with complex congenital anomalies, which is where myself and our team of surgeons from around the globe, largely within the US and Norway, participated. But since you are medical, this is pretty common, that you're seeing states of advanced disease with clubbing in a young child with oral cyanosis and even severe failure to thrive. Now, you can see this poor child, but this child was 2 years old. This is not an infant. This child looks like, I think it was was 8 months old. She's 2. So these are all because of cardiac cachexia from longstanding cardiac anomalies. This is one of the earlier patients that I was participating in, but you can see the children are very resilient. This is the first day after heart surgery. And they go from extreme states of shortness of breath to become a little kid again. And this is one of the reasons we do this from a impact and satisfaction perspective. Now, instead of going to a children's ward that you see here, this is the children's ward. So their room is to the right, and this is where they go to do their exercise. You could see this little cast on the child. He's got an active IV infusion. For those of you that know a little bit about valvular disease and rheumatic disease, this is a juvenile case of rheumatic fever with mitral stenosis. This is the actual image of the valve. The mitral valve is essentially near fused from acute inflammatory juvenile mitral valve disease from rheumatic fever. Part of what we contribute, and you may or may not know, I tend to do a little bit of valve surgery from time to time, and this is the valve after repair. And so these patients normally around the world get replaced. As you can imagine, replacing a young child's valve is problematic, either with a tissue valve, which will prematurely stenose within months or years, or a mechanical valve, which requires lifelong warfarin. And as you can imagine, living in the hinterland of the Caribbean, access to medical therapy to manage and monitor warfarin is not available. So our job is to try to reconstruct their valves. So with the assistance of our great team here, this is one of my colleagues, Dr. Jacobs in the background, and the child that you just saw is the young girl in the pink smock. And this is another patient that we operate on early on that had the same kind of valvular heart disease. Now, putting all this in perspective of that growth and development, it still had relatively humble beginnings. This is the open air barrack. That little blue thing that you can see in that picture is literally a portable. And that blue is painted steel that serves as the walls of this special area. And this was the cardiac operating room and its recovery. And we needed that insulated barrier because we had to keep the rooms cool in order to do heart surgery. We joke a little bit, but for many years, this was the sterile corridor where we transported patients from their room to the operating room. We carried them. There's no carts that you could roll into the OR. But that's how you got to the portable. Now, with a lot of work and effort and donations, and this is a whole nother page of this management of need, is to keep it sustainable, we had to raise money and donations. And this transitioned, this was where the portable was. We actually got enough funds raised and development through multiple things, it's a whole nother story, to actually build a brand new OR and cath lab. This is this year. This is our WVU team going down, and we're using this brand new space. Now, what I was saying is, how did we get here? This is on the wall of this new building, and it has to do with many years of development that included, of course, the Jamaican government and Prime Minister, but also Digicel, Chain of Hope, which is one of the bigger donations that and organizations that we use, the Rotary, Cardiac Kids Foundations of Florida, and a unique individual. I don't know if you can see what that is over there. Have you heard of the rap singer Shaggy? Of course, you probably don't, but everybody over here is nodding their head. So Shaggy became a friend of ours and was instrumental in supporting the Bustamante Children's, and donated to help do concerts and things like that. So we would go down and he would do a concert, and all of Jamaica would show up and raise some money. And so through this conglomeration of individuals and organizations, we're able to raise money. So in this process, we also helped the local surgeons. So as you'll hear time and time again from Dr. Fisher's organization, going down there and doing your thing, that's great. You feel good. Yeah, I've done stuff, but that doesn't necessarily help sustainable impact. So this is a picture that's actually made its way in our organization and the Society of Thoracic Surgeons, because you have 2 surgeons from Florida, myself, and this is the lead congenital heart surgeon from Norway, helping a local Jamaican young surgeon do a case. And this is the fundamental aspect of what we did. This is myself doing teaching of the residents and young surgeons of Jamaica over the years, doing wet labs and teaching valvular repairs. And in fact, this gentleman right here, I want to draw your attention to, this is Dr. Sherrard Little. So this is as he was transitioning from training to attending. He is the only pediatric cardiac surgeon in Jamaica and the Caribbean right now. And it's he who's doing these cases, because he's gone from this situation now to this is currently. So what you're looking at here is Dr. Little performing an operation, and this individual right here, this is my fellow that's currently actually getting a patient of mine prepared for I'm going to go to right now. This is Dr. Derajareski. So he's actually helping Dr. Little do a case. So it's a evolution. In addition to the actual physical aspects, we've done multiple educational aspects. And through this process, we've actually contributed to the academic development, not only globally, and these are publications that all came out of that experience, but also helping Dr. Little publish papers on the areas and challenges of managing rheumatic heart disease. And this is a journal called Cardiology in the Young. In that process, this is part of one of the techniques that we developed to augment the anterior leaflet of the mitral valve to reconstruct patients with rheumatic heart disease. And that I won't bore you with some of these details. You can look it up if you're interested, or if you're in any of your cardiac inclined, but maybe I'll show you a video to explain it. Instead of replacing the valve, we've done reconstructive techniques that take one's own autologous pericardium to rebuild the leaflets. And this is an example of what a rheumatic valve looks like. So those of you in medical school or in pre-medical school, you've heard of the fish mouth deformity. This is the fish mouth in real time. You can see it in a book, but this is really what it looks like. And so with that, what we do is we actually divide the fish mouth, the corners of the fish mouth, and then take one of the leaflets down and bring that into the ventricle. And then by so doing that, it results in our ability to take autologous pericardium and rebuild the hood of it. So it becomes almost like a sail. And with that, we're able to open up this valve quite widely and allow it to close quite reproducibly. So the existing anterior leaflet becomes the coaptation of the 2 leaflets. And then through that, we support it with a ring. And this is what it looks like. Now, we've taken this technique that's not solely developed in Jamaica, but partly here, of course, because we still manage that. And as you know, West Virginia does have its own share of endemic rheumatic disease. But this is an example of what this valve looks like now, 1 year following reconstruction. This is an echo, by the way. And so this is an example of a patient that we just did recently here of a 27-year-old Haitian woman with significant gradients. And this is the similar technique of what they basically have significant mitral stenosis. And if this is a video that we recorded for our national presentation, hopefully I'm not interrupting your lunch too much. It looks like everyone seems to be enthralled by this and not the opposite. So this is a case that we have to divide the papillary muscles, do reconstructive efforts to really open up the orifice. Acute rheumatic infection in the juvenile state is an acute inflammatory process. And sometimes that results in this fibrous tissue that we can peel. And so this young woman, we started peeling off of this whole inflammatory process. And this is a peel technique. And once that's peeled off, underneath it is the natural leaflets. And so in the younger patients, this is a technique that's usable. As once you get a little older, it becomes more difficult. But you could see already at 27, the degree of calcium was incredible. And so when that fibrosis becomes firm, it then tends to calcify. And once the calcification develops, we have to do other techniques. And this is a posterior leaflet expansion as opposed to the anterior leaflet expansion that you saw earlier. And so I'll basically detach the whole posterior leaflet, drop it into the ventricle, and so doing have a defect that can be expanded by use of autologous pericardium. These are all techniques that not only we take to Jamaica, but we also use here for the rare case that is premature rheumatic disease, so we can actually then reconstruct patients. And as a result, we then finish this off, and you can see this blanket of posterior pericardium. In fact, this patient was actually adopted by a WVU faculty member. And she currently lives here in West Virginia, so undisclosed location, shall we say. But this is the result of this technique. And the reason we did reconstructive efforts is at 27, obviously with a mechanical valve, young women can't have children, which is why personally, through the DEI efforts that Dr. Fisher is identifying, I'm very partial to when I go down, I have to make a choice of which cases to do. I tend to prefer young girls or women to do this because this affects their whole lifelong ability to have children. So when triaged, I tend to favor because of these long-term reasons. And this is the result of the valve afterwards. This is our next layer, not only doing efforts and doing reconstruction, is now, once they're able to do these types of cases, how do we advance care? This is our mission this year, in both helping the local team and actually helping the nursing team through an educational opportunity for our young people, that we've taken students and things down so that they can interact with the local teams. And this is a situation where these cases that we're doing now are pretty complicated. This is a case that we did on an unfortunate 11-year-old girl who was all of maybe 35, 40 kilos, who had cardiac cachexia, severe leakage of the valve, and an acute cardiomyopathy. So her ejection fraction was only about 25%. And we've developed techniques, we've brought equipment. The equipment's not complete and it's not up to date when we're doing these complicated cases. And so one has to be prepared. This is the valve in the middle of the valve repair. I had to close the cleft and do some reconstruction, but you always have to be ready. As I'm sure Dr. Wilson may have outlined, or some of other Dr. Fisher's lecturers, when you go to a foreign environment, you're not going to expect the shiny special equipment. You got to work in the local environment. In heart surgery, we rely on a heart-lung machine that pumps the blood. Well, we also have to be ready for these types of scenarios. In the middle of the operation on this very sick young girl, the machine shut down. The electrical connection to the machine was overloaded because the building itself didn't have enough electricity to handle. And so the pump shut off. And so we had to actually get out and crank the pump to support the blood supply of the patient. In my career, this has only happened one other time. But you have to be ready and adapt them. And so this is us doing it while he was literally hot wiring the pump to get it started again. As you can imagine, in the middle of an operation like this, when this happens in normal situations, that's a death. But with a good team, able to poise at a moment's notice, at a second's notice, to come to this activity, we're able to get this result. And even this young girl with that situation lived, and she's doing fine as of today. But it doesn't stop there. Part of our job is not only doing surgery and helping the local surgeons and teams and nurses, but also educating them and empowering them to know what the elements are, how to impact their population. These are usually attended widely by medical students, nurses, the physicians. The man on the front row here is the head anesthesiologist that was a close partner over the many years we've been going down there. And so I take us back to the management of need, both identification, authorization, and organization, but also reproducibility, expandability, and sustainability. And these milestones have been achieved over the course of our many years going down there, with increasing technical complexity, advancing disease states, and lasting impact, and transitioning from these mission efforts to a local surgeon operators, independent interval cases, a new OR suite through donors, really working carefully with the institution and the government of Jamaica, the local government, to make this sustainable. And it's not just sustainable based on our efforts. It becomes a national point of pride. So this institute now is a very prominent point of pride. In fact, Shaggy still has concerts to support them. But that gets to this whole aspect of sustainability. So heart surgery today in that environment is now done by, and it's a joint effort between the University of West Indies and Bustamante Children's. The vast majority of cases are now done by the local surgeons. This is Dr. Little, helped by his registrar, they call it. This is the British Ray. These are the perfusionists that are very good. And this is the large team of surgeons, anesthesiologists. It's kind of like a family down there. But these are the leaders of this country in their delivery of cardiac surgical care. But it does take a team. This is the team we brought down on our last effort, supported by Cardiac Kids Foundation, Chain of Hope. And some of these folks are from WVU, some are from Hopkins, some are from Florida. In the past, we had surgeons from Norway, Spain, Germany, but all of these folks really help make this a success. And so if we have time left, part of this gets now to the fundraising capability. And while we can do these types of things, we also have to appeal to donors. So part of that fiscal sustainability is putting this all together in messaging to the public, to industry, to any large financial bodies, both within the Caribbean, within the developing nations, but also within the United States. And so if I'm able, I'm going to try to play this video here and see if it plays. Yes, it seems like the sound is working. So hopefully you'll find this of interest.
Without surgery, most of them do not live, they die. For the surgeon, nurses, cardiologists, anesthesiologists, and care doctors works with the local Jamaica team, and each year we come here and try to operate as many children as we can and save as many lives as we can.
This is my colleague, Jeff Jacobs.
First, I say I'm very grateful for you guys doing with the money. And thank you for the meeting with the team up here.
Donations to this cause are absolutely critical because it allows this network to continue, and the impact goes not just to one child at a time, one suffering person at a time, but then allows the team to grow, flourish, and help dozens, if not hundreds more over time. Limiting factors of the cause is strict part of supplies. So we actually packed up 4 suitcases full of supplies, doing a lot of stuff. There was one of the scientists, ambulance, some other equipment that we brought down in, which we were able to do applications.
Good to be George to be here in Jamaica. As a matter of fact, I grew up next door, and I had a privilege to actually immigrate to the United States. And then I get to come back to Jamaica and get back with Edward Life Sciences and Cardiovascular Florida. This is such an important mission that the team of doctors perform here. And we are able to impact so many families, so many kids that are in dire need of these services.
I just want to thank you for giving us the opportunity to get back, and they guys really mean a lot to them in Jamaica, and mean a lot to us to come and help out.
We believe that each year we're saving 10 or more lives, but by partnering with the local Jamaican team, it's the opportunity to save thousands of lives. It's a big other baby that after that only babies 21 days old, we did the heart surgery on the baby before he did that.
Coming down to Jamaica, seeing patients, seeing the fact that we have in their lives. Do it sort of mission here. It's something you dream of, but it's really inspiring and something that I really can aspire to do as I continue to do medical education career.
Fantastic officers are thriving really well. A lot of backwork is good work to this to happen. I'm hoping for that for many years to come. University, the Cardiovascular people based in Florida, we give information to doctor patients already. This is a great opportunity for her patients who are in need and waiting for others to come around join the team. We really appreciate and thank you for your innovation and participation in the team.
We're really able to further this, and hopefully do more trips like this. All these rock stars and every sort of interdisciplinary study possible, it really provides the best possible outcome for the students.
For me, it's a personal vision. My elder brother passed away when he was 26 years old from heart failure because he did not have access to the treatment that was available. So I lost my brother. And so we have to think that everyone afford me to come back and do that. It's just so tremendous.
None of this would be possible without multiple supporters. First and foremost, Cardiac Foundation of Florida, Senator Corolla Lewis, and the Board of Creations have been the backbone and lifeline for this mission. We would also thank Edward Life Sciences the other Life Sciences Foundation for their generosity. Our other partners and supporters include Dan Newland, Shane Pope, Gifted Life, and the Rotary.
Thank you, Cardiac Kids Foundation, for being involved in this hospital.
I want to thank the Cardiac Foundation for all their help, all the donors who have made this possible.
Cardiac kids, you guys are the biggest part, and you truly are a lot of stars.
Well, with that, I think I'll wrap up and conclude. It takes a lot of organization and teamwork to do any of these missions. And I suspect you'll be hearing that theme throughout Global Health Week and all the efforts that Dr. Fisher's putting in. Thank you for your attention. Actually, we've expanded. So initially, single ventricle patients and others that are duct dependent were not done. They were shipped out if they had the means, or they just were palliative. But as we've evolved, now we're doing all the complex congenital hypoplasts. Those are rare, of course, but even a switch. So very unusual cases for an island nation, but those cases largely are done by the visiting team. All of the major, which is, your question's a small finite amount, but the vast majority of other cases are done by the local team. Good question, though. Yes, sir. No, this is solely funded right now from really multiple organizations. Cardiac Kids Foundation of Florida was really started by a group of us, really led by Jeff Jacobs, who you saw narrating. But it's a holding company that basically gets donations from thoughtful individuals and industry to help then execute the delivery of this. But no, we've not received funding from any other organization than those listed. So there's huge opportunities to fund other things. And so as WVU, while I'm connected to that mission because of my role in valvular therapy, even we've not supported it other than just going down there, bringing a team and helping with education.
Just say that this it's expensive.
Yeah, just I for the audience on the thing, I'll repeat what you were saying, because I think this is very good comment, in that these types of missions is a consciousness. It takes financial commitment. It's very, very important. And thank you for your comments, because I can't, say it better. This is a lifelong effort for not just those that go down, but for the sustainability of the providers in that island nation, who have become the magnet for patients from multiple developing countries and even semi-developed countries. Because this is now established there, some patients don't come to the US. First of all, they don't have the means to, but those that actually have the means, they'd rather maybe just go to Jamaica. Thank you. So these missions, and let me answer your second one first. These missions globally, we're not the only one. This is our contribution to that island nation, but there are other missions that are in Rwanda and sub-Saharan Africa, where remember that global map that was pretty much blank, to Vietnam, to Nepal, to multiple different countries by multiple different parties. Going down there, we go down there annually, and sometimes with COVID, there was 2 years we didn't go down, of course. But the missions are becoming less frequent because the team is doing more, and the teams are also supported by other missions like ours. That now that this structure is existing, it's a facilitation for a team from England, a team from Europe, to come when we're not there, and so this helps with the overall creation of that sustainability. Say that one more time. Yeah, that's a good question. So I'm just acknowledging the comment on the chat. I agree with this person. I just thought I'd show it. Thank you. There's not much to respond. It's a nice comment. So to say, how do we evaluate patients? So it's in several different stages. And so since we have a couple of minutes, I'll kind of describe this typical scenario. Early on, many, many years ago, this was done, literally by faxing. This is back in the days of fax, the details of the patient. Then it was an electronic submission with HIPAA compliance. And we try to look at echoes. They would send discs. I mean, it was fairly low tech. By training the local cardiology team, who are really great, they've now been able to help screen and understand self-triage to get a few cases ready. And then the surgeon, Dr. Little, communicates with us about 3 months in advance. So these are elective patients they have to populate. And then so we have a general sense. But if we were to say 20 kids are objective, they pre-admit 40. And then we have to triage. And that's actually somewhat difficult because they're all cute kids and young people, teenagers or whatever. And we have to pick because we only have a certain amount of resources to do a certain amount of cases during that mission. And the ones we can't do have to either wait or not get done. And that's the unfortunate reality of mission therapy, that we go down there, we have to not only pick what is the best outcome, what we can do, because all of these we can do, but some of them are either too high risk for the local team to care for afterwards, or they're going to be in an ICU bed for more than one day. Now, when you have limited nurses, which is the biggest challenge that exists there, is nurses and resources of beds, because it's a small place. If you have a patient in that bed for more than one day, you can't do another operation. So we have to reverse engineer that decision making to triage not just what we can do in that very moment of that very case, but the entire post-operative course of management, which is why we also have intensivists and other people come down and we educate their local team. So it's a fairly complex triage scenario that has to do with management of beds, resources, nurses, and outcome. All that comes down to how we pick. Finally, when we go down there, we have to be dynamic. So in that video you saw, if there's a newborn and we're happen to be there and they're otherwise that newborn's survivable in the United States, then we pivot and do an acute issue. Very rarely patients present with an acute congenital issue or an acute adult issue that if we're sitting there, we have the beds, we have the capability, we have to pick one over the other. And that was a case we did in a 21-day-old baby. And occasionally we've done an urgent case of a newborn. So, but that's very, very rare. And so it's a long answer to your important question in that it starts months in advance. It happens the day before the actual thing starts. And every morning we have a case conference. We talk about the patient from the day before, the patient's about plan for the next day, and every day that goes on with adaptation accordingly. Hopefully that answers your question. Yeah. So the question was the durability of reconstructive valve surgery. So unlike in congenital surgery, when you're closing holes or moving arteries around, not to belittle that, I'm not at all. It's much more, it's very complicated. These are reconstructive efforts, transplanting one's own pericardium to rebuild the valves. So durability of that is not known. We expect them to last, if they last the first year or second year, to last many, many years, because once the dynamic aspects of the valve are sustainable, it's not torn, it's not calcified. I could tell you that in the past, we used to use glutaraldehyde treated autologous pericardium. So basically that's a fixative that mimics biologic prostheses that exist off the shelf. We found that over time that tends to calcify. So I've abandoned biologic treatments or preservation treatments and just use autologous fresh pericardium, and found that lasts longer. Now, do I have 10-year results with echoes and follow-up? No. But from at least my experience from the handful of cases we're doing, they are sustainable. The problem in developing nations, whatever valve operation, even any operation you do, is follow-up remains a problem, because they go off and they're focused on other life issues. Their sustainability is not about follow-up for heart surgery, is about potable water, food, finance. That's their priority. Our priority is getting to the point that they can work on that. Thank you.
Thank you so much.
Sure, my pleasure.
Comment on in the chat, if you're still there, you had mentioned something that I'll just read it for me. This is the direction global health needs to move away